Good afternoon. I'm Steven Serneels. Thanks for having me today about this presentation about scaling digital solutions for healthcare access, telemedicine enabled by smart glasses. A lot of what I'm going to say today, you can find back in a scientific article that has been published some time ago in Global Health Action. Before I start sharing the findings of the pilot, I thought it was good to share a finding that was published just a couple of weeks ago on the potential of efficiency gains. What you can see is that overall live audio and video consultation always features amongst the top 2 of most efficiency gains possible in healthcare without jeopardizing the quality of the outcomes. The smart glasses started as a regular business, and so the biggest part of the application is in industry. But right from the start, we decided that we should make this type of technology available to create access to affordable quality healthcare for underserved areas at a different price point. The way you have to imagine this works is that a nurse in a rural health center puts on the glasses and she streams online what she sees through 2 cameras, a central wide-angle camera and a zoom camera. And it's the GP at a distance who can have an over-the-shoulder and can see as if he was on the location and sees what the nurse is seeing. At the same time, the mics and the speaks in the glasses allow for online instant communication between the nurse and the doctor. What is very specific about this type of smart glasses is that they're connected to the smartphone as well, which allows prior to the consultation to do a WhatsApp and connect with the doctor so that they get ready both, or after the consultation, for example, to type in data and log some of the information. The challenges we try to address are twofold. First of all, during the consultation to create access to affordable quality healthcare, which is in their need, mainly in sub-Saharan Africa and especially in DRC, as many of you, of course, do know. But the second thing we uncovered during the pilot is that this is also a great application to address the skill shortage, to upskill the nurses in the rural health centers, because they receive almost an online education on job while they're executing their consultation. The setting in the district of Kingandu is about 2 days driving from Kinshasa, 1 day to Kikwit on a paved road, and then another day on a dirt road, 200 kilometers to Kingandu. Kingandu used to be an old Jesuit town with 18 rural health centers, and our pilot was focusing on 3 out of those 18 rural health centers, supported by the district hospital in the town of Kingandu. Multiple partners have been involved, so the tech part of Iristick was only just one part. We needed an on-the-ground implementer, a trusted party that knows the settings, knows the population. That was MEMISA, and the Tropical Institute, the ITG, that was supporting us in ethical dimension, the medical dimension, but also in capturing the learnings and the publications afterwards. Of course, as I said before, the technical solution, the smart glasses and the connectivity, which in this case was done via VSATs, is only one dimension. Another critical dimension is to embed those smart glasses in the different processes. On the communication flow, for example, prior to the consultation with the smart glasses, the nurse is calling the doctor on WhatsApp, and the doctor is telling her, for example, he will be ready in 5 minutes to sit behind the screen and have the over-the-shoulder. During those 5 minutes, the nurse is doing the intake with the patient, logging the different data. The moment they connect with the smart glasses, she does a debrief to the doctor and the communication starts. So the communication flow, both for unscheduled calls, scheduled calls, calls for training, all had to be planned. It had to be integrated with the different medical protocols. The patient consent had to be integrated, and the data collection with the backbone system had to be provisioned as well. Infrastructure was a key element as well. The entire patient journey had to be covered. You can imagine it's quite frustrating, and we run into that problem when we were giving advice, or the GP was giving advice to the nurse that this was an emergency and the patient should come to the district hospital, that the patient, if he was not able to go to the district hospital or it would take too long, that this was, of course, a very frustrating situation for all people, and not the least the patient himself. Hence, we had to provide an emergency motorcycle to pick up the patient. Also, we learned during the pilot that we could enrich the consultation by providing the nurse with rapid diagnostic tests. So the nurse was taught in applying and using those rapid diagnostic tests without patients, but then when patients came, she was skilled and could use, with the help of the GP, to use an oximeter, a pulse oximeter, or a HemoQ, or a glucometer, which of course enriches very much the quality of the consultation. And last but not least, also the people themselves, to involve the chef de village and other people to make sure that trust was built before and during the pilot, but also the nurse-doctor relation, where before the doctor was visiting every 2 months the nurse and the rural health center. Now this was only almost on a daily basis. So that relation, who takes the lead, who has the final responsibility, also had to be monitored very closely. So numbers. In total, we did 629 teleconsultations. It's the nurse who decides when she will apply this digital support and when she wants to call the GP at the district hospital. This turns out to be 1 out of 10 visits. 39% of those 1 out of 10 visits then turns out to be a referral, and again 30%. So in total, 1 out of 100 visits turns out into an emergency case. This resulted in about 63 lives saved and around 209 lives improved. And what was critical as well is that the referral system itself improved as well. Not only the arrival, before people were sent but never arrived, in this case because the patient felt there was a connection with the GP who was waiting for him or her, felt that he or she then was expected, and hence did the travel to the district hospital, and the arrival rate augmented from 75% to 92%, but also the quality of the referral system was enhanced substantially. There were some other areas of qualitative improvement, which I already touched upon, the upskilling of the staff at the rural health center, the improved data collection, the increased confidence of the population. There was a 45% increase in visits to the rural health center. So that also were important qualitative outcomes. The learnings. Critical to assess right from the beginning, which we did not very good in the pilot, which we learned during the pilot, is that we better had to assess the full patient journey from awareness, visiting, the consultation itself, the referral, emergency referral, and the follow-up. That entire cycle should be covered. In the beginning, we focused too much on the consultation, the digital consultation itself, and hence we had to enlarge the full patient journey. The second thing we learned during the pilot as well is the possibility to enlarge the quality of the healthcare service by providing, for example, this rapid diagnostic tests. The alignment of the incentives was critical, especially for the nurses at the rural health center. In this case, because there was an uptake in visits to the rural health center of 45%, and the nurse got more revenue when there were more visits, these were aligned. The GPs at the district hospital didn't get a financial benefit out of this system. They were spending about, let's say, 15 to 20 minutes a day, supporting 1 or 2 calls a day. So the time investigating in this digital solution for them was limited, but they could see the bigger picture of the quality of the entire healthcare system, and also the upskilling of the nurses, where they had to spend less time in future in teaching them and training them. Trust was a critical element which we spent prior to going live with the digital solution. We spent about 4 to 6 months in reaching out to the population, the local population, to the chef de village and others, the district level, the national level, making sure that there was consent and support for this new way of providing services. Because of course, there is always this tension between traditional medicine man and this new way of working. Hence, trust was a crucial dimension as well. The danger of these type of projects is that this is a technology push. And in the beginning, you spend a lot of time on technology and making it work. Gradually, once that works, this goes to the background and becomes, let's say, a more basic element that is there, and other elements like integrating the processes, providing the infrastructure, and so on and so forth become much more important to provide a holistic solution. Cost-wise, I can easily say the upfront investment is substantial for a low resource setting. So the entire combination of the glasses and the smartphone cost about $1,500 per set, which is considerable for this kind of setting. The good news is that the operating cost is very low. These are very robust glasses. They can last a couple of years. The major operating cost is the telecommunication cost. And one of the learnings is that the VSAT communication cost is too heavy for these type of settings. So I would not recommend in future to go for VSAT communication. So of course, the alternative is to have Wi-Fi, telecommunication, internet communication, which is pretty low cost and makes this all financially affordable and sustainable. My last slide, you've seen this pilot on physical healthcare in Congo DRC. There are other applications in Mali on mental health care, other applications not on physical health care, but the support of the medical equipment and infrastructure, as you've heard in the previous presentation, to make sure that the whole infrastructure is up and running most of the time. We also are exploring this application in other continents like India. And we will start another application in Congo DRC, in Kinshasa very soon on prosthetics, where the combination of online support of the machinery and the equipment and the training of the people will all be integrated. So let me conclude right here. I hope you enjoyed the presentation, and if there are questions, we can take them later on. Thank you very much.